right, here we go.
Okay.
We're going to introduce perimenopause here, as we do with all of our podcasts. Get started with the joke of the day. Joke of the day. Joke of the day. All right. So, why did perimenopause get a lot of beads at Mardi Gras?
I don't know. Why?
Because of all of the hot flashes.
This is Stirrups, candid conversations in women's health. The podcast where we answer your burning questions and discuss the evolution of women's health through every stage of life. Join Dr. Randolph Scott and duly certified women's health nurse practitioner and certified nurse midwife, Kerry Autry, as they discuss the unique health concerns women face and share expert advice to assist you on your journey to maintaining your health and wellness. If you're looking for informative discussions, tips from qualified professionals, and a community dedicated to women's well-being, then you're in the right place.
It's definitely not a joke.
Right.
I think that's
right.
the problem.
That's not a joke. That's why we're here. Make sure we have a very open discussion about what it means to be perimenopausal. So sometimes, I define menopause because that's much easier to define, and then walk it back a little bit.
Yep.
So basically, menopause means that as you age, you get to the point where you stop having menstrual cycles. Estrogen levels have declined significantly, and there's a whole array of symptoms that you have. And those symptoms can certainly be very significant what the patient would experience. Mm-hmm. The only difference for perimenopause is that you experience all of menopause with your cycle. Yeah. And that's kind of how I like to frame it. Perimenopause is a very touchy time. The average patient that goes through menopause is about age 52. Mm-hmm. Now, menopause is the destination. That's where you have arrived. That's when you have arrived. Okay. But the journey.
That arrival. Oh,
yeah,
boy.
Yeah. But the journey sometimes can be a little touchy for a lot of patients. And so that's what we want to talk about, that journey now. In a previous podcast, I alluded to the fact that women are born with all the eggs that they will ever have in their lifetime. Mm-hmm. And the way that I try to communicate, at least to women who are not experienced or to the male side of things, is that, when you're born, you got a full tank of gas, and life is good. Or when you're born, you got $1 million, okay? Life is fantastic, okay? And as you go through life, you got less and less money. And you get into perimenopause, there's, quarter tank. Perimenopause is quarter tank, okay? Right. It's like, all right, now you're starting to get nervous about everything that's about you, and you're trying to look for that next gas station. Where is the next fuel pump coming? And sometimes that can create a little bit of panic and all kinds of symptoms. And so that's the way that, from a descriptive point, where things kind of take place. It is a journey, and it comes with a whole host of symptoms that the patient can experience. And so I'll let you talk about some of the symptoms that a lot of patients encounter, Kerry.
Yeah, I think for a lot of people, it's the unpredictability of the symptoms that make it so hard, that they can vary so dramatically. So when I'm talking to patients about this, because we talk about it with patients a lot, people are finally starting to come in and ask questions about it, which I appreciate. For a long time, we didn't talk about menopause, forget perimenopause, but it's gotten a lot of hype recently. Yeah. The New York Times has done huge stories on it. So people are talking about it, and patients are starting to come in and ask questions. So like you said, we're all born with like X number of eggs, and that number goes down every month. And as we started to get into our 40s, our brain hasn't figured out that it's running out of eggs. So our brain makes a hormone called LH and FSH, luteinizing hormone, follicle stimulating hormone. And those are made every month. And it's the brain's way of telling the ovaries it's time to make an egg. Mm. So they start off low and they get higher throughout the month. And when they reach a peak, you ovulate. And then a few weeks later, you have a period. That's the normal menstrual cycle that you go through your entire reproductive life. At some point in your 40s, usually, sometime in your 30s, but at some point in your 40s, your brain is going to make all the LH and FSH, and it's going to say to the ovaries, it's time to ovulate. And your ovaries are going to say, I don't have any eggs. And your brain's going to be like, no, it's time.
Yeah.
So it makes more LH and FSH. And the ovaries are like, yeah,
I don't know about that
anything.
idea.
Like, I got nothing. And the brain's like, no. And it makes more LH and FSH. And then suddenly the ovaries are like, you know what? Actually, we found 3 eggs. So now instead of ovulating the one that we were supposed to a week and a half ago, we're going to ovulate 3 eggs. Now, most of your circulating estrogen comes from those eggs. So now you went from no estrogen to 3 times the amount of estrogen that you're supposed to have. Then you ovulate all 3 of those eggs and your estrogen drops off a cliff. So what you end up with is this completely unpredictable swing in hormones. And you get this fun place where we live for years, where you have all the symptoms that come from way too much estrogen and all the symptoms that come from no estrogen. And it goes back and forth. And so when we're talking about managing perimenopause and all the symptoms that come with it, what we're really trying to do is minimize those crazy swings and bring it back to a more predictable up and down like it's been your entire life. That's, of course, until you run out of eggs altogether. And then we start managing menopause, which is a different thing. But in a lot of ways, it's actually easier to manage for most people because it's more predictable.
Right.
So when we're talking about perimenopause, you talked about symptoms. The average age of menopause is 52. Perimenopause can be anywhere from 7 to 10 years, sometimes longer. So that means for 7 to 10 years prior to 52, so starting in your 40s, you can start to experience these symptoms. And they are varied. It can be low libido, painful sex, urinary incontinence, urinary tract infections, recurrent urinary tract infections, vaginal dryness, vulvar dryness, urinary frequency, breast pain, fatigue, dry skin. Are you getting the idea? Like this goes on and on and on. Night sweats, hot flashes, period changes, meaning that you still get a period. It's infrequent and it tends to be really heavy and uncomfortable. Insomnia, weight gain, and now we're gaining weight in the middle. We've always gained weight in our hips and thighs, but now in perimenopause, you start to put on weight mid-body. Heart palpitations, that one scares the heck out of people. You'll be laying in bed and all of a sudden your heart just feels like it is pounding out of your chest. And you're not anxious about anything. You're just laying there thinking, oh my God, this is it. This is it.
Yeah, it's my moment.
And then you finally fall asleep. Hair loss, texture changes to your hair, brain fog, forgetfulness, impaired short-term memory, inability to focus. That's why I have to have this list. Poor word retrieval, anxiety, difficulty concentrating, just a feeling of, I just don't feel like myself anymore. And that's probably the biggest way people describe it when they come in. They're like, I just don't feel like me.
Oh, Kerry, it's so many things and so much to so many people, but the one thing that is just maddening for folks is the loss of control. Mm-hmm. Is that
and predictability?
I just don't feel like myself, or I just feel like I can't control my emotions. It's a very challenging time because for so long, everything for most women has been predictable. Exactly. I knew a couple of days out of the month I was going to have these challenges, but now I can't call it. I can't see it. And that becomes the most disconcerting, feeling that at least what patients describe to me.
And the memory thing and the brain fog, that people find frustrating because, for a lot of us in our 40s and 50s, I talk to patients all the time, like, we've done all the things, right? We went to college, or we had our careers, or we had our families. We raised our kids. We've gotten to this point where we're, fairly dependable people who have accomplished all these things. And then you're talking to your boss and you can't remember the word pharmacist. No guess who that happened to. Talking to my boss, cannot remember the word pharmacist. How many times a day do I use the word pharmacist? And I'm like, the guy with the medicine at the store. But this really happens to people, and you feel like you are going crazy, and you feel like you lose credibility with your family, with your employers. And it's a really tough space to be for people who have reached a point in their lives where they feel like they kind of had it under control.
I hope I wasn't that boss. I don't remember that anyway, Kerry.
Perfect. Like, he knows. He knows. He'll forgive me.
All right. And so with all of that and everything that happens, A is to recognize that things aren't quite the same. And so sometimes that, not the same is okay, but you got to embrace it at the same time so that, when things do come up, that you're charged to help meet some of the needs that you actually have. And so that's where we focus on the next really, that you have it, that things are not quite right. What do you do about it? And so how do you manage? Now there's a variety of ways. That list, we have to look at the list to make sure that we're incorporating everything. So there's usually no one single thing that's going to be helpful, but we start to go through the list. And so management becomes important for patients. And so what are some of the things that patients can do to help manage some of their symptoms, Kerry?
So, I always talk about goal setting and, journaling. I'm very big into journaling when we're talking about people who are managing perimenopause, because very often they'll come in and they'll say, I have these 2 problems. I'm like, okay, that sounds pretty good. Like, I can manage that, 2 problems. And then I say something like, but, just with the way I work, I tend to send them a list of things that I see. And I'm like, I want you to just kind of live with this list and journal over the next couple of weeks and then come back. When they come back, the list is usually more like 10 to 12 things, because they'll usually say something like, I had no idea that this was all connected, or these things crept up so slowly that I didn't even realize how bad I felt. So when we're talking about managing perimenopause, of course, all providers are different. But for me, my goal is for you to come back in this office and tell me, I feel good. I feel like myself. And until you say that, we're not done. Yeah. And that looks different for every single person, because your perimenopause is very different from my perimenopause. And the things that are going to work for you are not necessarily the things that would work for me. So the other thing I say to patients is, I just need you to have some patience with me as we go through this, because I'm not going to get it right the first time. Fingers crossed, but odds are good I'm not going to get it right. And we're going to have to make some adjustments as we go. So keep up that journal. Keep telling me what worked, what didn't work, and we'll keep moving things around until that day you come in and tell me you feel great. I'm sure a large part of it is that I'm kind of in this space as well. So I get it. I use myself as a guinea pig all the time. But I think also because I come from a different place, I'm not a doctor, I'm a midwife and I'm a nurse practitioner. So I work in a lot of different spaces. So we talk a lot about nutrition and sleep and stress management and herbs and supplements and prescriptions that are hormones, prescriptions that aren't hormones. And then there's the compounding pharmacy, which is a whole separate thing with a whole separate set of choices. So we first have to kind of establish where you feel comfortable working, because, we have patients who are, they want to dig into this identity. They're going to see themselves as wise women, right? Mm-hmm. That they know all the things, they have all these life experiences, and they want to understand herbs, and they want to talk about their hormones endlessly. And that's where they live. And then we have patients who are like, what can you give me that I would feel better yesterday? And those are 2 very different sets of goals, right? And 2 very different ways to get there.
Right. Management wise, as you were saying, it's not a one size fits all. And, the driver a lot of times, for perimenopause is, you're trying to get back to yourself, and in the midst of all of this change. And unfortunately, though, there's no quick way to do it, because the changes are taking place. And as you're changing, and as you're trying to help the patient, it's hard to grapple and to provide that level of control that they're actually looking for. And so you do have to have an approach. I love your introduction in the sense that you said, hey, how about journaling so I can really figure out what's going on? Because usually it's not just 1 or 2 things. Mm. You thought it was, right, but you uncover so much more when you start to think about all the transition that's taking place for you. I can't find my keys,
Ever.
like, where's my car? Dude, where is my car? Keys. I can't find it. And so I think you have to have an approach that is holistic, that you have to touch on a variety of things in order for the patient to start feeling themselves again, so to speak.
So when we're talking about that, of course, nutrition, one of the biggest complaints I get in perimenopause is weight gain. Mm. And one of the challenges is that we start to lose muscle mass in our 30s. And muscle is, of course, like the driver of our metabolism. So as we lose muscle mass, your resting metabolism rate just tanks. So you start to gain weight, and you start to gain it in the midsection as opposed to your entire life. So you got to start to change your relationship with food. Instead of worrying about calories, I'm like, just forget the calories. I don't care about calories. What I need you to do is I need you to prioritize protein. And then I know you used to run 15 miles a day. Great, but stop. I now need you to really prioritize weight training, because we got to put the muscle back. It's the only way that we're going to start to get the weight off.
I think it's critical that you say that, and because there are changes that are taking place that you don't feel physically. Right. Your bone health actually changes. Mm-hmm. And that's very important, because, when you're 70 and you're facing a hip fracture, what could I have done along the way to help minimize or mitigate some of that?
Right.
And so, it's just not the external or how you're feeling. It's, what's happening with your body and the transition.
All those physiological changes that are happening.
I
feel like I should call out for the cardiologist. You still have to do some cardio.
That's right.
Before the cardiologist
before they bash our
you got to still do a little bit of cardio, but I don't need you to run 2 hours a day. I really need you to prioritize the weight training over hours and hours of cardio. So, really taking a look at nutrition and possibly very, significantly changing your relationship with food and how you're really kind of keeping track of the things that you're eating. Then when we start to talk about herbs, there are so many amazing herbs out there that can do a lot of things. The downside to herbs, and I love herbs and I use them all the time. I probably recommend herbs 3 to 4 times a day. But they tend to be more single symptom management. Sometimes I can get a few things out of them, but they are not a complete holistic approach. So we tend to be using a couple of different herbs to get a couple of different things. So my favorites out there, I use Vitex a lot. I actually use Vitex a lot throughout the lifespan, but in perimenopause, Vitex, the old name for it is chase tree. They changed it to Vitex. I guess it's the part of the scientific name, but I guess they just decided it sounded more medicine-y.
Yeah.
So you'll find it marketed as both. It's a phytoestrogen. So it's like putting estrogen back in the body, but without any of the risks of estrogen. So again, it's minimizing those crazy swings, because your body's like, oh, I have a little bit of estrogen. So I don't have to make so much or have so little. So we use that a lot. It helps with the hot flashes. It can help with the energy. It can help with a lot of those kind of daytime symptoms. You'll also see black cohosh mentioned a lot. And, I don't know why it's big in Europe. For whatever reason, the Europeans, their go-to is black cohosh. Mm-hmm. In America and Canada, we go to Vitex first, but both are safe. Both are good options.
Yeah. That's often one of my tricks. To help manage some of these symptoms, even in menopause too. I think that's a very helpful agent for patients.
Absolutely. Mm-hmm. Then, if we're talking about sleep, which is another big, big problem for our patients in perimenopause, they don't sleep, they have hot flashes, they have these sudden, people who have never had any history of anxiety suddenly have anxiety at night, and it's pretty severe anxiety, or the palpitations. I love valerian root. Great herb. It's a non-habit forming sleep aid. It will help with the night sweats, which is huge. So you'll get to sleep and get better sleep when you get there. Downside to it is it tastes awful. It has the most bitter taste. So you can do it as a tea, but if you're going to do the tea, you got to get a good blend. And there are some really great blends out there. So if you're like a tea person and you want to just make that part of your nighttime ritual, you can get a nice valerian root blend tea. Or if you just want to do capsules, definitely an option as well. So I love the valerian root for nighttime. For the memory stuff, which is huge, I have really been recommending a lot lately something called lion's mane. It's a mushroom. It's a really crazy looking mushroom. If you've ever seen one, they're pretty funky. You should look them up sometime.
I'm going to do that right after the show.
Yeah, it's quite the thing. So it actually comes from Chinese tradition, but there's some new research out that not only does it help with the memory and the brain fog and the word retrieval and all that, but it actually looks like it may decrease your lifetime risk for Alzheimer's. And women are at a disproportionately high risk for Alzheimer's. So because I'm often kind of piecing things together, when I can get a couple of things out of one item, I am all for it. I want the most bang for my buck. So those are some of my 3 go-to herbs, and I use those a lot in practice.
Well, that's fantastic as a summary there, Kerry. I wasn't aware of that last one there. So that's certainly I'll be adding to my arsenal. I appreciate that.
I know, right?
Yeah.
And then for supplements, usually we're looking at some DHEA. DHEA is a little bit tricky though. It's widely available. People like it. It can help with energy and libido. It's a hormone that's made by the adrenal glands. And one of the things that happens with it in our body is it can be made into testosterone. So it can be a nice roundabout way for us to get testosterone up without actually putting patients on testosterone, which comes with a lot of complications. It's not impossible and we do it, but it just comes with a lot of complications. We can talk more about that later. But DHEA, we can bring that testosterone up with an over-the-counter product. It will help with energy, libido. It can help with mood. It can help with a lot of memory stuff. The downside to it and why I don't recommend that people just in general take it without having a provider who's helping them is that you can actually push the testosterone too high. So when I start people on DHEA, I do usually bring them back just to kind of check and make sure we don't have them on too high a dose of DHEA. Because once we start to push that testosterone too high, you start to get acne and weight gain. You can even get voice changes. Turns out that's the one non-reversible symptom for too much testosterone.
Yeah, that's hard to walk that one back.
Everything else, if we get you off the testosterone, it'll all go away. But the voice deepening once it's there.
Yeah, so you got some Barry White in you. That's probably too much. Okay, you want to scale it back a little bit. But yeah, so DHEA, I agree. That's certainly a great one to use. And from a hormonal aspect, now hormones. We're talking about hormones. My hormones are out of whack. Should I take hormones?
We do put people in perimenopause on HRT.
Yes, we do
all the time, and it can be a little bit trickier for people, but it's very doable. Yeah. It's one of those things that it's not as quick a slam dunk as it is for a menopause, just because people in perimenopause are still cycling. So sometimes we have to play with the dosages or the way that we're doing it,
right?
Because otherwise they just sort of spot throughout the cycle. Mm-hmm. I usually try the most straightforward path first, just because we already can't remember things. So if you tell me I have to do something only 25 days out of the month, I'm going to be in trouble. So I try the most straightforward path. But if people start having a lot of spotting, then we'll have to adjust that. But we absolutely use, estrogen, progesterone, of course, as part of HRT in perimenopause and menopause. Sometimes testosterone, and sometimes even we have to take a look at the thyroid. Yeah. Your thyroid gland just doesn't work as well as you get older.
And, we speak about hormones. Things have changed so much. When I first started prescribing hormonal therapy for patients for both menopause, perimenopause.
The pharmacist would call you every time and be like, "Are you sure?"
They still do that.
Sure? They do. Are you really sure? I'm like, I'm really sure.
No, I'm joking. But, we used to have patients on loading doses, where you put them on for like 30 days or 2 weeks, and then scale it back to twice a week. And
it's gotten significantly easier.
Yeah, it's gotten a lot more manageable, and the recommendations certainly have changed in terms of that too as well. But so yes, hormones are certainly within the arsenal. And then sometimes, non-hormonal therapy is things that you've talked about, but sometimes you got to create your own concoction there. And so just kind of give them a little bit of some different remedies by getting things compounded.
Mm-hmm. Right. So then we were talking about going through a compounding pharmacy, which I have to say I don't do it very often, and in large part because at this point, thank the Lord, we've gotten to a point that most HRT is covered by insurance.
Yeah.
So we're sending a prescription to your pharmacy for your hormones. It's picked up by your insurance. It's easy for patients. Compounded pharmacies are never covered by insurance. So you're always looking at an out-of-pocket cost for those. But, for some people with very specific circumstances, it really is the best choice.
Yeah. And so that rounds out a very exhaustive view of management and how we can actually help patients at the same time. But in the same way that, there are a lot of symptoms that can take place, and trying to meet that need, trying to find the provider to help you meet that need sometimes can be a challenge too, because I think this is a topic that's underappreciated and not really taught a lot for providers who are going through their training, medical school, and so forth. And so finding somebody that's well-versed in it certainly can be a challenge, but there's ways around that too at the same time. There are actually organizations, there are forums that can certainly lead you in the right direction to find providers that can help and assist you in the direction that you may need. And so, how do you think that patients should come in when they have symptoms, concerns regarding menopause? Because, some patients can't really describe it. Some patients can, but, when you're sitting down with the patient and you're trying to figure out, best means to take care of these patients, trying to address some of their concerns, what should they have ready and available?
One, a huge dose of patience.
Okay. All right. Yep. Patience for the patient.
Patience for the patients. Well,
Okay.
and patience for the provider too.
Yeah.
This is not the type of thing that you're going to see a provider once and walk out with it all fixed. This is a process. So it really is important that you find the right person, because even once we get you to the point where you're like, you feel great and you're riding it and everything's going well, 6 months later, something's going to change and we may have to start all over. So just finding somebody that you can form a relationship with and start to keep that provider informed of where you are, what's going on, any changes in your medical history, any changes in other medications that you're taking, because that can be really important.
Right.
But for that first visit, when you're going to go meet this provider for the first time, I always point out to people that, for better or worse, the way medicine works in this country, the average doctor's visit is about 18 minutes. So you've got 18 minutes to communicate your concerns, ask for what you need, and then walk out with a plan. So that's really hard to do unless you come in really organized.
Yeah.
And we've already covered memory problems and concentration problems are a huge part of perimenopause. So write it down before you go in to see your provider. So you want to come in with a really good history, your medical history. You want to have a bit of a family history. You want to have a good sense of at least your family GYN history. You want to bring a list of any medications that you're taking, any supplements that you're taking, because they really do matter. People think that, because you can buy it at CVS over the counter, that it doesn't make a difference. But we were just talking about herbs that do things in the body, and they do things in the body because they change the physiology and the chemistry inside the body. So it matters what you're taking. So a list of what you're taking, both prescribed and not prescribed. And then, and then a list of your concerns. I really like it when my patients come in with their concerns ranked. Like I want a list of your top 10, and put it in the order that matters to you.
Yeah.
I don't usually have a problem with that. That's usually pretty automatic, but bring me your list ranked, and then any recent lab work that you've had drawn, because there's a good chance I'm going to ask for labs. And if you've had labs drawn somewhere else and now I have to go back and forth with that provider to try and get them, that just slows everything down and increases the risk that you're going to get billed for getting labs drawn twice. So bring anything you've got with you.
I think that's great in terms of expectations of what we would expect the patients to have. But man, you couldn't have said it any better. You got to have patience through this process, because if you're on 10 different medications, when you come into the office, And I have to review those medications and see how they interact. And perhaps are they contributing to your symptoms or they're not? And how can we help best manage with the medication that you're on? Sometimes that becomes a part of that 18 minutes that I have to get through and still be able to help you at the same time. So the understanding that this is probably going to take several visits before things are figured out and how we can best help you in going forward.
And we may be asking you to communicate with other providers. Like, let's say that one of your biggest complaints is low libido, but then you come in and you're on an SSRI. Well, that's a big part of your problem. So now we need to start communicating with another provider. Can we get you on a different medication? Can we start to get this dosage down? So sometimes it's also that we have to communicate with other people to help sort of tailor your care, to look at it holistically.
And I think that is a theme that we want to stress really throughout all of our podcasts is the communication is important. Communication with the provider, communication with the patient, communication with other providers, communication with the partners and spouses about this particular circumstance. Oftentimes I see patients, they are so frustrated because they've been through this process. They need help. And it's getting to the point where it's affecting their relationships. Their partners are not necessarily not understanding, but sometimes it's hard to recognize these changes when things have been relatively smooth for the most part. And so it becomes impactful in a lot of ways. And I think communicating where you are and what's happening is very important. I mean, if you're experiencing vaginal dryness, that's going to impact your libido. That's going to impact your desire to actually want to have sex. It's going to be painful and you're going to move more away from it. That starts to impact relationships. And so recognizing the problem, but also communicating that so that some assistance can be made and directed so that you can get past this particular experience. And so if nothing else, we want patients to recognize that sometimes it's an issue. If it is, certainly reach out to your provider so that they can help you. Choose one that certainly is well-versed in this particular area. And I think we all win in that situation. So this was a fantastic discussion. Certainly we'll have more to talk about, more podcasts, but thank you for listening.
Thank you for joining us on this episode of Stirrups. Be sure to send us your women's health questions and topics you'd like to cover by visiting our website, CarolinaEliteWomen.com. If you enjoyed today's episode, please subscribe to the podcast and spread the word by sharing it. To find out more information about Carolina Elite Women's Care, visit CarolinaEliteWomen.com. This podcast is edited and produced by Earfluence. Stay healthy and stay empowered. We'll talk to you soon on Stirrups.